looking for.
More in the middle there.
Okay, go.
Hi there, welcome to our Facebook Live. I'm Tobias Carling from the Carling Adrenal Center, so thank you for joining in. This week is the Pheochromocytoma paraganglioma awareness week. It's the Pheochromocytoma awareness week. So we're gonna focus today's Q&A, question and answers about pheochromocytoma. So we're very excited coming from the Carling Adrenal Center. So I'm gonna get right into it. We got in some really great questions. Most of them are focused on pheochromocytomas and paragangliomas. But we have a few sort of general questions. And again, thank you so much for sending in the questions. They're all very appropriate and important to talk about. So the first question, what are the most common symptoms of pheochromocytoma that people often miss or mistake for anxiety or panic attacks? Yes, so pheochromocytomas are often underdiagnosed, misdiagnosed, or just not picked up, and that's because the symptoms can be very variable. So almost half of patients have no symptoms at all. But an easy way to remember the the symptoms of pheochromocytoma are the 5 P's. The 5 P's of pheochromocytoma. So you have paroxysmal hypertension. That means hypertension that can be blood pressure that can be normal, but then you have these spikes up and down. That's the first P. Second P is perspiration, meaning sweating. Pallor, that people can turn pale because that's due to that adrenaline flushing. Pain, usually headache is the most common, and then palpitation. But then you can also have other symptoms like tremors. People have tremors. But what's important to know is a lot of patients been told they can't have a pheochromocytoma because their blood pressure is normal, but often the blood pressure at the baseline is normal. It's only elevated when the patient have one of those spells. The spells are when you have a release of metanephrine or catecholamines, meaning the adrenaline from the adrenal gland. You have these spells that usually last about 5 minutes where your blood pressure can go super high. You feel your heart is racing, you start sweating, you're having tremors, that sort of fight or flight experience. But those are the typical symptoms that are often missed and thought to be anxiety or panic attacks that are associated with pheochromocytoma. All right, next question. How dangerous is it to wait for surgery once a pheochromocytoma is diagnosed? How dangerous is it? Well, so like all tumors that overproduce hormones, they're not all equal. So there's a spectrum from small tumors that have very minimal elevation in the adrenaline levels to big tumors that have super high levels. And it's not a perfect correlation. Sometimes you can have a smaller tumor that's very active, and you can have a big tumor that's not very active. But the severity of the disease is related to a large extent how high the hormone levels are, as well as how long the patient has had it for. So if you have a pretty small tumor, your symptoms are pretty minimal, your blood pressure is pretty normal, and your hormone, the adrenaline levels are only slightly elevated, well, it's not a huge danger to you. But if conversely, if you have a big tumor, your hormone levels are sky high, you're very symptomatic, well, then it's more dangerous. So obviously the sooner you can get the tumor out, the better. I have a right pheochromocytoma that's 3 centimeters. My doctors say it looks benign, but I'm scheduled for an MIBG scan and surgery soon. Why is the scan important if it already looks benign? Yeah, so on adrenal.com we have a whole chapter about imaging for pheochromocytoma specifically. And in almost all cases, just a good adrenal protocol CT scan is enough. That's for the most patients. Sometimes if you have elevated hormone levels and a positive CT scan, boom, you're done. That proves you have a pheochromocytoma. But like in real life, there can be gray areas. For instance, if your lab tests are sort of borderline, and sometimes doing what's called a nuclear medicine scan can be helpful. The other reason is to exclude the risk that you have what's called metastatic pheochromocytoma. Metastatic pheochromocytoma are the ones where it can spread elsewhere. So in those scenarios, it can be helpful to do an MIBG scan, or even a better scan nowadays is what's called a 68 DOTATET PET, which is a functional PET imaging, sort of similar as PET you use for cancers, but you use a very specific tracer called DOTATET. And that's a great scan. So there's no danger in doing those scans. It's just that most people don't need it. And we can go into a whole section talking about healthcare efficiency, and there's a lot of inefficiencies in healthcare, and we're doing a lot of imaging and studies that you really don't need, and that's a whole different topic. But that's the reason why your doctor want to do an MIBG. They want to be 100% sure you have a Pheo. But if you already have a 3 centimeter tumor, your adrenaline levels are high, you have a Pheo, you need to take it out. My brother is starting phenoxybenzamine before surgery. What are the risks with this medication, and how do you make sure patients are safe during the procedure? Yeah, so phenoxybenzamine is what's called an alpha blocker. So there's a few different types of alpha blocker. Phenoxybenzamine is one of them. We actually don't use that very much anymore because it's very expensive, and the other ones that are cheaper, including doxazacin and prazosin. The risks of the medication is the same reason that we use it, meaning the purpose of that medication is to lower the adrenaline levels and lower your blood pressure in preparation for surgery. It's not that the surgery necessarily is dangerous, but you can have wild swings in your blood pressure during anesthesia. To lower that risk, patients go on alpha blockers beforehand. So the risk of the medication is that your blood pressure goes too low. So some people can feel sort of faint after taking the medication. They can have what's called orthostatic hypotension, meaning you get up from lying down or sitting and you feel like the room is spinning. That's because your blood pressure drops. That's what we call orthostatic hypotension. So that can happen with this medication. In truth, though, people focus a lot on alpha blockers. The way we do it nowadays with modern surgery, it's very rare that you even need to be on alpha blockers before surgery. But it's in every medical endocrinology textbook, so most endocrinologists will put you on an alpha blocker. There's a lot of data coming out from Europe that it's only really necessary if your adrenaline levels are sky high. But that's how alpha blockers are used in preparation for surgery. How large of a pheochromocytoma can be removed with mini-back scoperctomy? Could a 5 centimeter tumor still be done this way? Yes, absolutely. So we just went through our data on pheochromocytomas, and we're writing up a couple of scientific articles about our experience, but our average size is 4.2 centimeters. And you can certainly do the mini-back scoperctomy up to about 7, 8, 9 centimeters for pheochromocytomas. Again, it's not as simple as just the size. It has to do with the size of the patient, if they have other comorbidities, if they've had previous operations in the area. So there's a million different things that factors into which surgical approach is the best for an individual patient. But for a 5 centimeter peritypical pheochromocytoma, yes, for sure, the mini-back scoperctomy is by far the best operation. I have a 3.2 centimeter adrenal adenoma that's been known for years but keeps getting dismissed. I am now dealing with high blood pressure, an arrhythmia, heart rhythm issue, flank pain, muscle weakness, and even abnormal pregnancy hormone levels at age 55. Could all this be related to my adrenal tumor, and what should I do next? Yes. So first of all, I'm not entirely sure with what the question writer means with abnormal pregnancy hormone levels, but tumors that are producing androgen, meaning either male or female sex hormones, we take very seriously, because the risk of those being concerning in terms of the risk of adrenocortical carcinoma is a lot higher. So if you have elevated testosterone, elevated estrogen, especially in men, we take that very, very seriously. And there's a lot of precursor hormones called, for instance, DHAS as well. So yes, so I would have to review all your lab informations, but this is certainly something that needs to be further investigated for sure. If part of the adrenal gland is left behind to preserve function, is there a risk the pheochromocytoma will grow back in that tissue? Yeah, that's a great question. So it has to do with the risk of recurrence after function preserving surgery. So when you operate on pheochromocytoma, if you spill tumor cells, they can implant and they can grow back. That's what's called pheochromocytomatosis. So that's why expertise really matters when you do this operation. So if you spill tumor cells, they can grow back. But if you do a partial adrenalectomy and you don't spill any tumor cells, it doesn't grow back. That's a curative surgery. Except for a few instances where you have what's called local invasion, meaning the tumor has sort of a cancer potential and it starts growing outside the capsule into the surrounding tissue, then it can come back. The other important thing to know is that about 20% of all patients with pheochromocytoma have an underlying tumor susceptibility syndrome. So MEN2, von Hippel-Lindau, neurofibromatosis type 1, the SDH type mutation. So about 13 different genes been found to predispose patients to hereditary pheochromocytomas. And if you have one of those genetic conditions, you're prone to develop tumors in both sides. And in that scenario, the tissue that's left behind is not genetically normal, meaning you have that drive of producing tumors. So for those patients have a much higher risk of having tumors on both sides. But we have to balance the risk and the benefit of the risk of recurrence, but also the risk if we were to take out both adrenal glands. Obviously, if you take out both adrenal glands, you're not going to have a recurrence. But what's the problem with that? Well, the patient is then adrenally insufficient for the rest of your life. So that's where this idea of partial or function preserving surgery factors in. So the most important determinant in that is whether there's a metastatic potential of the tumor, as well as if you have a pre-existing genetic condition that make you prone to develop pheochromocytoma. So overall the risk is super rare, especially at the major centers, but especially those patients that have a genetic condition, they need to be followed the rest of their lives with an endocrinologist to make sure they don't have a recurrence. This question ties into sort of the same thing. Can pheochromocytoma come back after surgery? Have you had cases with multiple recurrences, and how are those managed? Yeah, so again, it has to do with the malignant potential and the genetic predisposition. when you have a recurrence of pheochromocytoma, so we have seen cases where they had their initial operation, say 20 years ago, and they have a genetic predisposition and you have a recurrence. In many cases, we can go back and do a operative adrenalectomy to remove the tumor, but again, it's completely individualized. But certainly, whenever you can, whenever it's feasible, surgery is the number one treatment of recurrent pheochromocytoma. Okay, so this question is about diagnosis. I've had 24-hour urine tests repeatedly come back high, but my plasma levels are normal. Could I still have pheochromocytoma even if blood work is always normal? Yes, so that is very, very rare. For all practical purposes, if your plasma levels are completely normal and you have a scan that doesn't show an adrenal tumor or paraganglioma, the risk that you have a small tumor that's missed by those scans are very low. What's important to know about both the 24-hour urine test and the plasma test, that there are false positives, and there are some medications, a lot of medications in fact, that can falsely elevate your adrenaline levels. So it's very important that your doctor goes through exactly what medications you take, and even some over-the-counter medications can push your adrenaline levels up. So it's important to know, but so you would have to have your doctor go through that. But if all your testing is normal and your scan is normal, the risk that you would have a pheochromocytoma is exceedingly rare. Why do pheochromocytomas sometimes cause sudden spikes in blood pressure instead of consistently high readings? Yeah, that's a great question, and that has to do with this paroxysmal hypertension, meaning so what happens in the pheochromocytoma is that it's releasing adrenaline into your bloodstream, but that doesn't happen at a constant rate, right? It's not like drip, 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 drip. It's bursts of adrenaline flowing into your system. And that's why the blood pressure spikes up and down. And that's very typical for pheochromocytoma. So it's, and sometimes the release of adrenaline from your adrenal gland can be precipitated by certain things. So for instance, certain foods, certain drinks like coffee, sometimes wine can cause release of catecholamines. Sometimes when people go to the bathroom and have a bowel movement, that can increase the intra-abdominal pressure and it releases catecholamines or adrenaline, and your blood pressure spikes. So that's why the blood pressure spikes. What's the difference between pheochromocytoma and paraganglioma, and does it change how surgery is done? Yes. So the difference between a pheochromocytoma and a paraganglioma is real estate, meaning where does it occur from? So a pheochromocytoma arises from the adrenal gland. A paraganglioma is from the same cell type, but occurring outside of the adrenal gland. So another way to put it is pheochromocytomas are intraadrenal, paragangliomas are extraadrenal. And paragangliomas can occur anywhere from the neck all the way down to where your urinary bladder is located. So it can be in the chest, it can be in the retroperitoneum, in the abdomen, it can be in the neck. And so of course, the operation for pheochromocytomas, the best operation, as you know, is the mini-back scoperctomy whenever that's feasible. The operation for paraganglioma is completely individualized based on where the paraganglioma is located. So sometimes we can do it through the mini-back scoperctomy if the paraganglioma is above what's called the renal hilum, meaning where the renal artery and vein enters into the kidney. But if the paraganglioma is in the chest or in the neck, obviously the operation is completely different. if pheochromocytoma runs in my family, when should my children be screened and how often? Yeah, great and important question. So this is for patients that have a genetic predisposition. So again, it's about 13 different genes, and this is changing every year. Most commonly nowadays, you have genes that are in very rare instances or families, but the most common one are SDH type tumors, familial paraganglioma, multiple endocrine neoplasia type 2, neurofibromatosis type 1, and von Hippel-Lindau. Those 4 are the most common. So if you have one of those genetic syndromes, then because they're all autosomal dominant, meaning your offspring, your children, have a 50% risk of inheriting that specific gene mutation from the carrier. So again, it is individualized. A lot of pheochromocytoma care has to be individualized, and why is that? Well, it's because with certain genes and certain mutations, you can develop a pheochromocytoma as a 9-year-old, right? And then if you have a different type of mutation, you may not develop a pheochromocytoma until you're 50. So it all depends on what gene is affected and what mutation and how and what we call in genetic terms the penetrance, how often that manifests itself in a certain family. So some cases, children have to be screened. Sometimes you can wait until you're 18 and be screened after that. But the most important thing is that you see a center where they have an interest and expertise in genetic types of pheochromocytomas, and then you go on an individualized program. There is good literature on this where there's international guidelines of that recommends screening dependent on what type of mutation you have and how often that should be done. But in general, the combinations are lab testing, meaning plasma and 24-hour urine-free metanephrines, and then imaging. And in this scenario, screening in familial cases, a lot of this new functional PET imaging is very helpful, including the 68 DOTATET PET is often the best. But again, it depends a little bit what type of gene mutation your specific family has. What role does genetic testing play in pheochromocytoma, especially with newer variants like the MAX gene or MEN5? So same thing, we sort of talked about that. It's individualized. So some of these newer genes, may have a very low prevalence, meaning there's only a few reported cases that's been found. So having comprehensive genetic testing and seeing a genetic counselor who can sort of explain the genetic testings, the pros and cons of genetic testing, and what the implications are in the individual case is very important. Can pheochromocytomas cause long-term damage to the heart or kidneys if left undiagnosed? Yes, for sure. As you can imagine, living with very high adrenaline levels affects every cell of the body, because the adrenaline levels or the metanephrines are circulated through the bloodstream, and it especially affects the inner lining of blood vessels, so the endothelium. It affects your heart muscle, puts you at risk of strokes, heart arrhythmias, heart attacks, and a lot of cardiovascular and kidney disease. So for sure, if you have pheochromocytoma undiagnosed, it's going to cause damage. And the damage is correlated to how high the hormone levels are and the duration. How long have you had it before you get diagnosed? Fortunately for pheochromocytomas, a lot of that damage is reversible, but obviously the sooner you can reverse the detrimental effects of the hormones, the better. Why is it necessary to prepare patients with alpha blockers before surgery? What happens if you don't? Yeah, so we spoke a little bit about this. Alpha blockers are used to lower the adrenaline levels before surgery with the idea that you have less of blood pressure swings during the operation. And as I mentioned, that's often standard. In most cases, to be honest with you, it probably doesn't matter that much, because with modern surgery, where this operation is done in 15-20 minutes, you're not going to run into trouble. But for really big tumors with very high levels, going on an alpha blocker is fine. So what happens if you don't? In most cases, if you have an expert anesthesiologist and an expert surgeon, nothing really happens, except you might have a little bit more blood pressure elevation, similar as you're doing. If you go and do bench press, your blood pressure is going to spike to 230, 240, right? So it's similar blood pressure elevations as you have during hard workout. But again, for really high big tumors that are very active, it's certainly very helpful. Are pheochromocytomas usually benign, or how often do they turn out to be malignant? Yes, so most of them are benign, and we actually don't use the term malignant anymore for pheochromocytoma. We used to use that term, and that might seem like just semantics, but the reason is we can never know whether a pheochromocytoma is malignant or not by just looking at it. The only difference between a more aggressive pheochromocytoma or not is if it has metastatic potential. So we talk about pheochromocytoma that have metastatic potential, meaning that they can spread outside of the adrenal gland. And that's about 10% of all cases. So that's why it's so important that after surgery, we want to see what the pathology shows, but then you want to follow with your endocrinologist. The good news for pheochromocytomas is we have an ideal tumor marker to follow patients with, and that's your labs, right? Your metanephrine. So metanephrines before surgery, and the tumor comes out, your metanephrine comes down and that's normal. Then you just follow that metanephrine, and if that's normal, that means that the tumor is very unlikely to ever come back. But say 5-10 years from now, the metanephrine is creeping up again, then you have to worry about what's called a recurrence, meaning that the tumor has come back. So that's how we follow patients long term with pheochromocytomas. If someone has symptoms like palpitations, sweating, and headaches for years, how do they know when it's time to push for pheochromocytoma testing? Well, if you've had symptoms for years, you should have been tested years ago, right? I mean, what's the point with going around with symptoms when you can easily rule it out? And I'm not saying all of those symptoms will always be a pheochromocytoma, but it's a simple lab test, so why not check it? So I would say years ago, you should be tested. Are there cases, this is an important one. Are there cases where diffuse adrenal hyperplasia, or another term for it we use is medullary hyperplasia, without a visible tumor still behaves like pheochromocytoma? Yes, there are such cases where, meaning that you have an expansion of the medulla, meaning the inner lining of the adrenal gland that produces adrenaline, but you don't have an obvious tumor, and that's what we call adrenal medullary hyperplasia. Number one, that's super rare, and number two, in most cases that occurs in the setting of a genetic predisposition with one of those genes we were talking about before. So it's rare, it's usually related to a genetic syndrome, but it does occur. What's the long-term follow-up like after pheochromocytoma surgery? How often should patients have scans or labs? Yeah, so again, it depends a little bit in what context, but assuming the final pathology is benign and you're not part of a genetic syndrome, then I would not recommend having scans here. I would just follow those adrenaline levels, but you should follow that at least once a year. There's some instances where you have to be followed a little bit more carefully, and often that's related to the genetic predisposition syndromes. We're actually doing annual scans. Often one of those functional PET imaging is helpful. So again, it's individualized, but the combination of labs, you should always, at the minimum check once a year. Certainly you want to do that at your first follow-up visit after curative surgery, but then yearly after that. And then in some instances, in an individualized manner, you should have scans as well. What's the difference between a functional adrenal tumor and a non-functional one? This is sort of a general question, but a functional tumor overproduces hormones, a non-functional does not. Non-functional tumors can produce adrenaline, what we call pheochromocytomas, that's what we're talking about today. But you can also have functional tumors overproducing cortisol, what we call adrenal hypercortisolism, or Cushing syndrome, or subclinical Cushing syndrome, or mild autonomous cortisol secretion. This disease have confusingly many names, and we're trying to fix that. So we're writing a couple of papers about streamlining both the terminology when it comes to Cushing syndrome, as well as creating a disease severity classification. But anyway, you can have cortisol producing tumors, Cushing syndrome, or subclinical Cushing syndrome, or aldosterone producing tumor. Another name for that is primary aldosteronism, or PA, or Con syndrome. So those are the three big groups: adrenaline, cortisol, aldosterone. If a scan shows an adrenal tumor that isn't producing hormones, should it still be removed? If you have a tumor that's non-functional, all the hormone testing are completely normal. There's a few, so the vast majority of those patients do not need surgery. However, there's some instances when still, if it's non-functional, it needs to come out. So here we talk about something called the imaging phenotype, meaning what does the tumor look like on the scan? So we look at about 10 to 12 different characteristics on a CT scan or an MRI, but it has to do with how fat containing it is, what the borders look like, how it interacts with surrounding structures, if there's calcifications, and so forth. So we look at the imaging phenotype and the size and whether it grows. So imaging phenotype, what does it look like? How big is it, and is it growing? If it's growing, if it's over 4 centimeters, or if it's have an atypical imaging phenotype or looks indeterminate. Sometimes we use the term lipid poor adenomas, meaning so a classic adenoma has a lot of fat inside of it. A lipid poor tumor is a tumor that doesn't have a lot of fat, and those we take a lot more seriously because the risk of cancer is a lot higher. So again, if it has an atypical or indeterminate imaging phenotype, if it's growing on multiple scans, or if it's over 4 centimeters, with some rare exceptions, those tumors need to come out. What should patients look for when choosing a surgeon for adrenal surgery? So a number of things. So the number one important thing to know is that the vast majority of surgeons in the US perform fewer than 6 operations per year. So the typical number of operations per year is one per year per surgeon. And of course, it's hard to be an expert on something you do once a year. So the number one thing to look for is experience, but then obviously their background, where they're trained and in what discipline. Most adrenal surgery in the United States are performed by endocrine surgeons. So if they have undergone what's called an endocrine surgery fellowship, that's usually a good sign. But also some adrenal surgery is performed by urologists and general surgeons. But in general, endocrine surgeons are the ones that have the best training for adrenal surgery. But even if they are endocrine surgeons, they may not do a lot of adrenal surgery. Some of them do just parathyroid and thyroid surgery, and maybe do a couple of these operations a year. And this can be tricky operations, so this is definitely an operation that you want to have the most experienced person to perform your operation. And for many patients, frankly, that means the best option is to travel for your operation. How long does recovery usually take after adrenalectomy, and when can patients return to normal activities? Yeah, so for the best operation, the mini-back scopeadrenalectomy, the operation takes about 20 minutes. You spend one night in the hospital. Already the next day you shower, you can go for a walk, that sort of thing, but don't do any heavy lifting for 2 weeks, meaning more than 20 pounds. For people, but you can be up and around, but don't do any sit-ups or push-ups or pull-ups. You know, they put a lot of strain on your core muscles for the first 2 weeks. For people that work, so it again depends a little bit on your jobs. A lot of people that have more like an office type of job can be back within a few days to a week. People that have a more physical job, like a nurse or a firefighter or a cop, they may need a couple of weeks or even 3 weeks sometimes before they return. What are the main differences between laparoscopic adrenalectomy and the mini-back scope adrenalectomy you perform? Well, so first of all, occasionally for really big tumors, like this, I also perform laparoscopic surgery. So the best way to go about adrenal surgery is you tailor the operation to the patient, right? But for greater than 97% of our cases, the mini-back scope adrenalectomy is the best operation. And there's multiple pages on the website that explains in detail why this is a better operation. But it's much faster, it's safer, less pain, faster recovery, less trauma to the tissues for the patient. If you go through the belly, you have to, just to get to the adrenal gland, you have to move the bowel, you have to move the spleen, you have to move the liver, you have to do a lot of dissection just to get to the adrenal gland, whereas if you go through the back, the adrenal gland is right there. So whenever it's feasible, that operation is just much, much better, especially for patients that have had previous surgery. So if you had previous gastric sleeve or gastric bypass or gallbladder surgery or colon surgery or hernia surgery or any type of operation in the belly, it creates what we call adhesions, meaning scar tissue from the previous operation. So if you then have to operate again on that patient, you can spend hours just digging through scar tissue from the previous operation just to get to the adrenal gland. And of course, the more dissection you do in scar tissue, the more risk you're going to have bowel injury or some other thing that's just related to difficult operation due to previous operations. How common are adrenal tumors overall, and how often are they something serious like pheochromocytoma? Well, so first of all, there's a lot of adrenal tumors that are serious, not only pheochromocytoma. I understand we're doing Pheochromocytoma Awareness Week, and certainly pheochromocytomas are serious, but cortisol-producing tumors causing Cushing syndrome are very serious too, and so are primary aldosteronism, because both those type of tumors creates significant increased risk of high blood pressure, heart attack, weight gain, strokes, early death. So all adrenal, what a lot of people don't know is that functional adrenal tumors, the risk of dying, meaning the risk of mortality from these tumors, approaches some major cancers. So these are not, just because they're not cancers doesn't mean they're not, not serious diseases. This you can speak to any patient that had, a 1 centimeter aldosterone producing tumor, and after a few years of having atrial fibrillation and high blood pressure and low potassium and a stroke, they certainly think that that tumor is serious, even though it's not cancerous and it's small. So it's the damage due to the hormones that matters. It's not the size of the tumor. But I understand where you're coming from. So how often is it, I think what you meant to say, how often is it functional where you need surgery? So adrenal tumors become more common as we age. So it's pretty rare in your 20s to 30s. So if we find an adrenal tumor in a patient that had a scan for some other reason and they're in the 20s and 30s, we take that very seriously, because it's rare in that patient group, but if they do occur, they're much more likely to be functional and they're much more likely to be cancerous. If we do scans on a 70-year-old, almost 5 to 7% will have small tumors on the adrenal gland, and the vast majority of those excuse me, are not functional and do not need surgery. The key is for us as doctors and as medical endocrinologists is to figure out which are the ones that are functional and not functional, because a lot of the functional tumors can be left alone, but the functional tumors, even though they're small because of the negative impact of the hormone overproduction, can be very serious. So is it possible for both adrenal glands to be producing the same amount of cortisol? How do you treat this if both glands are affected? Yes, so we see a lot of patients with so this has to do with adrenal hypercortisolism or Cushing's syndrome. So when you have too much cortisol from the adrenal glands, it's due to either one tumor or multiple tumors. That's true for all endocrine disease, but for cortisol producing tumors, that's true for aldosterone. You can have one aldosterone producing adenoma, or you can have multiple tumors, right? And that's true for cortisol. So for cortisol, for adrenal hypercortisolism, 2/3 have one tumor on one gland, and the other gland, both on that side and on the other side, is completely normal. So you have just a single adenoma. That's 2/3 of patients. But 1/3 of patients have overproduction of cortisol from both adrenal glands, what we call bilateral adrenal hypercortisolism. So they have multiple tumors. So that's pretty common. So 1/3 of all cases. And the best way to treat that is you do what's called a function preserving surgery. So sort of what we call a Goldilocks operation, right? So there's two goals with the operation. Goal number 1, get rid of the tumors. Goal number 2, preserve enough adrenal tissue that you don't end up being glucocorticoid replacement dependent, meaning that you have to take hydrocortisone the rest of your life. So practically the way that works is that we often start with a bigger tumor, or the bigger side if there are multiple tumors, and then we'll see what the cortisol levels do. And for some people, the cortisol level come down so much that they can wait a significant period of time, because the cortisol is normal. They can wait a year, 3 years, 5 years, and some people, that's all the surgery they need. But those that then have still high cortisol levels, or 3 years from now the cortisol is creeping up, you do a partial on the other side. So you need about 1/3 of one adrenal gland to have enough cortisol production that you don't need to be on long-term hydrocortisone. So we obviously check that very carefully, but you want to preserve at least 1/3 of one gland to make it function preserving. So the next question is sort of tied to that. What is the risk of adrenal insufficiency after surgery with you? Is the risk higher with other surgeons? Well, I can't speak, for other surgeons, but again, it's in the context, right? So what's important to understand with adrenal insufficiency is sometimes what we want, right, for cortisol producing tumors. So our risk for adrenal insufficiency in pheochromocytomas and hyperaldosteronism is essentially zero, right? Because they don't have cortisol overproduction that suppresses the normal adrenal cells, meaning they put the other normal adrenal cells to sleep. The exception to that rule is there's a small percentage of both aldosterone-producing tumors, aldosterone-producing tumors and pheochromocytomas that also overproduce cortisol. But when you operate on patients with Cushing's syndrome, they come in with the cortisol levels up here, and obviously we want the cortisol level to drop. So what it does is that it drops and it overcorrects, and for a period of time we need to supplement the cortisol production because the normal cells are being put to sleep. But that's obviously what we want, because that's a proof that the patient is cured. So that's a good thing. You just have to cover that period of time. So people call that adrenal insufficiency, but technically, that's the purpose of the operation. The reason we operate in the first place is to fix the high cortisol. So it depends. Again, it might seem a little bit like semantics, but adrenal insufficiency is the intended purpose of the operation when you operate for hypercortisolism. So last question. After 15 years, I have no diagnosis other than an adrenal tumor. I suspect a pheochromocytoma. What do you suggest I do next? What needs to be tested to confirm the diagnosis? Yeah. So so the best way to figure out if you have a pheochromocytoma is you need to have those lab testing that we talked about. So again, the plasma metanephrines as well as the 24-hour urine-free metanephrines. Again, if those are normal, it's very rare. That's very unlikely that this is a pheochromocytoma. If you're still convinced that that's a pheochromocytoma, that would be the time where a functional scan like a DOTATET PET or a MIBG scan can be helpful in those really sort of murky type of cases where the diagnosis of a pheochromocytoma can be a little bit tricky. That's rare, but it does occur. We're actually writing up a scientific article about what we call normal hormonal or silent pheochromocytomas, meaning those patients that have lab testing that's pre-normal, but lo and behold, when we do operations for other reasons, for instance, an atypical imaging phenotype or some other reason, it turns out to be a pheochromocytoma. So because we see more pheochromocytoma patients than anybody else in the world, we literally see everything. So we also see those patients, but those patients are very, very rare. A more common thing is that both the doctor and the patient believe they have a pheochromocytoma, but they might have a small aldosterone-producing tumor. We actually see that a lot because the symptoms are very similar. So again, the most important thing if you have an adrenal tumor is not only have your adrenaline levels measured, but also the other adrenal hormones. So thank you so much again for listening in. Please bring awareness to pheochromocytoma during this week. Talk to your friends and colleagues and anybody who is willing to hear, because we definitely need more awareness, not only about pheochromocytomas, but about all adrenal disease. So please spread the word. And again, thank you so very much for checking in with us.